right, good morning, guys. Hopefully you saw my email that your lecture exam number 3 grades were posted yesterday afternoon. The average was not as great as I normally like to see. It wasn't horrific. It was about 72-ish, which isn't horrible, but I usually like my averages to be between 75 and 80. I know a lot of people are feeling very frustrated by their exam number 3 grade. I do think a lot of that has to do with the snowstorm, whether we like it or not. I think you guys were out of class and having to learn through lecture recordings, which is not something I love to do, but it just kind of is what it is. And remember that we always have the optional final. If your grade was brought down by your exam number 3 grade, you always have the chance to make it up. So it's not like all is lost, but I do understand the frustration. I wish I had a better solution. If you had one for me, then you're welcome to send it to me. But I did the best that I could in this situation. And just to warn you that you will be getting, so the other part of the makeup, like I said, I only did part of the makeup. That's why we pushed our test back. Now, in order to catch up to our current schedule, we have to do a little bit more catch up. And I'm going to be doing that over the Mardi Gras break. So hopefully this Friday, before you leave, I'm going to post extra lectures to catch you up to where we should be. And so then you'll have all of Mardi Gras break to kind of catch up on those 2-ish lectures. Now, there's not going to be anything due or anything like that over Mardi Gras break. It is a break. And you don't have to watch the recorded lectures over Mardi Gras break. It's just highly recommended. Okay, take the extra 3 days and watch 2 or 3 hours worth of lecture and study it. Okay, it's always better to view those recorded lectures earlier than later. You're always welcome to ask me any questions if something is confusing, but if you wait until the last day before the exam to watch it, which I suspect a lot of you did for the last exam, which is why you didn't do all that great, there's not a chance to answer questions or anything like that. Okay. And as always, you are always welcome to come by my office to check out your exams, exam number 3 or 2 or 1, to see what you did wrong. We can talk about it, why you got a question wrong, why I gave you the number of points I did on a short answer question, whatever else you want to know. You're always welcome to come by my office. You can just come by during my office hours, or you can schedule an appointment. I will warn you that this week is a bit busy. I have lots and lots of advising appointments, so you are welcome to just come by my office, but you may be waiting for a bit because I am an advisor. I have like 50 advisees, so yeah, you may be waiting a little bit, but I'm happy to meet with you. You may just have to wait a tad. Or if you want to wait till advising is over, that always works too. Okay? Anybody have any questions about any of that? About the exam or anything? Okay, so today we are moving on to our our next module, right? Module number 4. And module number 4 is my favorite section of the class. And I know it's a lot of people's favorite sections. I think it's the one that most people find the most interesting. It is all of the infectious diseases. So we're going to be talking about which microbes cause which diseases, what their symptoms are, how they're treated, all that fun stuff. Now, I will warn you, and for some people this is a good thing, some people this is a not so great thing, is that this portion of the class involves the most memorization. Okay. There is less pathways of understanding, right? Like the immune system, it's very much like a pathway. You have to understand the whole thing and how things interact with each other. You have to understand the different components. It's more understanding a pathway than it is memorizing. Memorizing is a big part of it, but in this part, there's less pathway and more memorizing. It's just memorizing the diseases, what symptoms they cause, what their hallmark symptoms and signs are, how they're treated, all that kind of stuff. So that for some people, that's good. A lot of people do really well on exam number 4 because it is kind of just a memorize-y test, and a lot of people are really good at that. Some people don't do as well because they like the pathways or they find the pathways easier. But this last section is going to be a lot of memorizing. And if it's up on the slide, you have to know it. Okay, there's going to be a lot of stuff on these slides. I tried to keep them kind of the same, so you have to know exactly the same things for each organism and disease that they cause, and that'll make more sense as we go through it. But yeah, like I said, this is my favorite part. I think it's the most interesting. The only caveat that I will give to this, or the other little warning that I will give, or a couple of warnings, sorry. The first one is we are going to see, if you've looked through any of the lecture slides, if you scrolled through them at all, there are some pictures that are kind of gross. Okay? And I don't do this as a scare tactic. I don't do it for the entertainment factor or to freak you out or to gross you out or anything like that or to upset you. I understand that it can be, we do have some pictures of babies that are sick, and that can be really upsetting. I'm not doing it to scare you or for entertainment value. I'm doing it so you know what it looks like. So if you ever come across this in your healthcare career, you will know what it looks like. And I do my best not to put anything too graphic. When I'm capable of doing so, I choose the least disgusting, for lack of a better word, the least disgusting picture. But there will be some gross pictures. I'm sorry if it's upsetting. I understand that it's upsetting, but there's a reason that I have them up there, and it's not just to make you feel bad, okay? They're up there for a purpose. They're for teaching. And then the other kind of caveat that goes for this whole section, so all of the chapters we're going to be talking about, is I am going to be talking about, for this class, right? This class is an overview. This class is supposed to be a basic survey of microbiology and diseases. We are not going to cover every single thing that causes every single disease. What I am going to do is cover the most common scenarios. But what that means is I don't want you to hear, we're going to be talking about like soft tissue infections. I have the causative organism listed as Staphylococcus aureus. And I don't want you to think that I have that written because Staphylococcus aureus is the most common cause of soft tissue infections. If somebody tells you someday that Strep pyogenes causes soft tissue infections, that is also true. They are not wrong. I'm just telling you the most common ones. Okay, so if you read somewhere else or you hear somewhere else that something else causes these types of infections, it's probably also right. I am just covering the surface. And it's also true when you're talking about microbiology. One of my favorite things to say is that any bacteria or any virus, almost anything, can cause almost anything if it's given the proper chance. Okay, I've seen normal skin flora cause meningitis. Okay, I've seen gonorrhea cause arthritis. All right, anything can cause anything if it's given the proper chance. If it's introduced to the right place at the right time with the right immune system, almost anything can do almost anything. But again, we're talking about the most common scenarios. So just keep that in mind as we go through this. And as you go forward, because I know for a lot of you, this is one of the first classes you're taking in nursing. And as you get into clinicals and stuff like that, or working in a hospital, you're going to come across a lot more things. And those things aren't wrong. I'm not wrong. I'm just talking about the most, well, I could be wrong, but I'm just talking about the most common scenarios. So just keep that in mind. All right, so we are breaking these down by chapter, and each chapter goes through a different system. So chapter 16 is where we're going to start, and chapter 16 covers infectious diseases of the skin and eyes. So we kind of start on the outside, and then we're going to go through each organ system individually and talk about the diseases that affect those organ systems. Starting with the skin. So before we can talk about diseases of the skin, we have to talk a little bit about their anatomy. So the skin is made up of three layers. The outermost layer is the epidermis. And the epidermis is the kind of hard layer. We talked about what this was made of in the immune system. So it's made out of dead skin cells. And then what protein? Does anybody remember? Keratin. It's made of dead skin cells and keratin, which is a hard substance. Remember, the epidermis is what keeps most bacteria out. It's kind of the hard outer layer that protects the inside of our body from pathogenesis, from being infected. The dermis is the middle layer, and this is where most of the glands are. This is like, for lack of a better word, this is kind of a gross word, but this is like the meat of your skin, right? This is where all your glands are. This is where your blood vessels are. You can kind of see them in this picture here. The blood vessels grow across the bottom. This is a hair follicle. You have sweat glands. All of the juicy bits of your skin, all of the alive and important parts of your skin are in the dermis. And then the subcutaneous layer is mostly fat and what we call connective tissue. Okay. So that's the tissue that underlies your skin. It's kind of what holds the skin together. It's the muscle and connective tissue in the subcutaneous layer. And that's the innermost layer, the part that sits closest to the inside of your body. Okay. And most of this should be pretty intuitive. I mean, you've all had like some kind of wound where you've just like scraped yourself and like the outer layer of your skin is damaged, but you don't bleed, right? And that's just because your epidermis is damaged, right? You gave yourself a little bit of a scrape. If you cut yourself deeper than that, or you get like a true road rash or something, and it starts to bleed, it's because it's going into that dermal layer. And if you expose your muscle, then you have a very, very deep wound that has gone past the epidermis and the dermal layer. Now, as far as normal flora on the skin, we've talked about this a fair bit. There is a whole lot of normal flora on your skin, right? Thousands of different species, millions of different individual cells, if not trillions of individual cells, exist on the outside of your body. They're going to be of, again, dozens of different types of bacteria, but the two big important ones that we're going to talk about, the biggest genera or genuses of normal flora on human skin are Staphylococcus and Streptococcus. Staphylococcus and Streptococcus. Now, again, there are others. There are dozens of others. But the two major contributors of normal flora to your human skin are Staphylococcus, lots of different species of Staphylococcus, and lots of different species of Streptococcus. Okay? And again, the big thing to note there is the outer layers of your skin have a lot of normal flora. When you touch things, you are distributing normal flora. When you touch somebody else, you are picking up their normal flora. We are constantly interacting with normal flora on our skin. There's a lot of it, which can lead to lots of infections. Okay, so we're gonna break this down by organism type. We're gonna start off by talking about bacterial infections of the skin, then we're gonna talk about viral infections, and finally fungal infections. We'll talk about the different categories. All right, so our first one are soft tissue infections. And these soft tissue infections in general are infections that are generally what we call superficial, meaning they stay in the outer layers. So these typically stay in the epidermis and dermal layers. So the epidermis and the dermis. They don't frequently go below that, though they can. But usually if they go deeper than that, then it changes infection types. It becomes something else. So typically when we're talking about a soft tissue infection, we're talking about the soft tissue, not the connective, muscle, hard tissue. Talking about the soft stuff, the fat layers, the dermal layers, the outer stuff. Okay. And again, this can be caused by a lot of different things, but the major contributor of soft tissue infections is this bacteria right here. Now, another warning, I guess, is I am not going to ask you to spell these organisms. You're never gonna have to remember them, but you do have to know which ones go where. Okay, so like I'm never gonna give you a short answer question that says, give me 3 different causes of otitis media. And then you just have to pull those names out of nowhere. If they are going to be written in your test, and you will have to recognize them, but you're never gonna have to pull them out of nowhere, if that makes sense. All right, but you do have to know which organisms cause which diseases. This is where that memorizing comes into play. Specifically, the most common cause of soft tissue infections is what we call, what is that? It's not a fire alarm, is it? Okay, stop. It didn't stop. A fire alarm would be way louder than that. All right. The most common cause of soft tissue infections is Staphylococcus aureus, most frequently what we call MRSA, or what you might have heard of as MRSA. And what MRSA is, the MR stands for methicillin resistant Staphylococcus aureus. So the MR is methicillin resistant, and then the SA part is Staphylococcus aureus. This is also commonly known as a staph infection. If you've ever heard that word before, oh, you've gone to the doctor because you have like a weird bump on your arm, and they say, oh, you have a staph infection. This is what they're talking about. You have a soft tissue infection caused by Staphylococcus aureus, staph infection. Now, MRSA in particular is, we'll get to that in a minute, but methicillin is another name or a type of penicillin. All the illins, right? Penicillin, methicillin, oxacillin, all the illins are in the same group. And this particular form of Staphylococcus aureus is resistant to all of them. So a lot of our basic antibiotics that we would use to cure these types of infections, Staphylococcus aureus learned how to be resistant to it decades ago. So the main signs and symptoms of Staphylococcus aureus soft tissue infections are raised, tender, often open lesions. Now the big kind of hallmark symptom here are going to be lesions or wounds that produce pus. Now, as we go through this, again, this is kind of something that applies to all of the things we're going to talk about. A lot of the symptoms are going to be the same, right? There's going to be a lot of infections that have fever or redness or swelling, right? There's going to be a lot of them that share a lot of symptoms. The biggest things that you want to remember, and trying to memorize every single one of those is going to be basically impossible. So the one you want to try to remember are the ones that I emphasize. So the ones that I say are kind of the hallmark signs and symptoms, that's the one that you want to remember the most, okay, the one you want to focus on. And for soft tissue infections, the big thing here is these often open lesions filled with pus. Staphylococcus aureus is known for producing pus-filled infections. And these raised, tender, open lesions can vary wildly in what they look like. So a Staphylococcus staph infection can vary from anything like this, which is a very small, this looks like something that you would get after shaving, right? It's like an ingrown hair, or sometimes you get this if you're wearing a tight bathing suit for too long, you get any kind of skin irritation, and that Staphylococcus aureus can get into those teeny tiny little wounds in your skin caused by the irritation and can cause these very, very tiny little infections. A lot of us have experienced these. You get pimples or, again, any kind of skin irritation caused by chafing or shaving, anything like that. Maybe these teeny little infections that go away very quickly. A lot of us have experienced those in our lifetime. But they can vary all the way from these teeny tiny little micro-infections to this absolutely massive open wound that this person has on their back. And if you can't tell, that's like the back of their hip. The bottom of that picture is their buttocks. And so this is the back of their hip, and you can tell that spreads pretty far across their back. That's gotta be 6 inches across, at least. That's a huge infection. So a staph infection can be anything from this teeny little infection that's gonna go away on its own to this absolutely massive open wound that requires surgery and IV antibiotics. But the thing that they all share is that they produce pus, right? These are little pus-filled wounds. They're very, very tiny, but they're pus-filled wounds. You can see the pus being produced in the middle of this wound here, and then this is obviously a large pocket of pus right in the middle there too. Okay, so those often open lesions that produce pus, those are the big ones that go along with soft tissue infections caused by Staphylococcus aureus. Now, transmission/prevention of this Staphylococcus aureus, because it is part, so Staphylococcus, like we just said, is part of the normal flora of the skin. So Staphylococcus aureus is often part of people's normal flora. There were estimates that I read not that long ago, I think I have it written down, that it's possible that up to 60% of the human population has Staphylococcus aureus as part of their normal flora. And so Staphylococcus aureus is spread from person to person, usually through direct or indirect contact, especially, most commonly, in public shared spaces. Specifically things like gyms and locker rooms and shared showers, right? Especially places where you're naked with lots of other people, like a shared locker room where you're changing clothes, you're taking a shower, you're touching all of the surfaces, then somebody comes behind you and touches all their surfaces. That is the most common way that Staphylococcus aureus is spread. It can be spread through things like handrails on the subway or at Disneyland or anything else like that. Public shared spaces, because people are coming in contact with other people's normal skin flora. And it can be spread very quickly through casual, direct or indirect contact. It doesn't take much to cause a soft tissue infection. And the best prevention for soft tissue infections is hygiene. So washing your hands, making sure that your body is clean, not touching public surfaces whenever possible, wear shoes in a shower if you're going to the gym, stuff like that. The most common group that get these types of soft tissue infections are young athletes, so young adult athletes. And that's just, that just makes sense, right? Young people in general, particularly young boys, are not the most hygienic group of people, right? They don't know how to take care of their bodies yet. They're new to this whole producing lots of sweat and stinking really bad a lot of times. I have a 9-year-old son. He reeks all the time, right? So it's just, we haven't figured out how to do it yet. Haven't figured out proper hygiene. Puberty is happening. It's a weird time. And then you add in shared spaces like locker rooms and gyms, and you add in, like if they're playing football, they're covered in these sweaty pads that they sweat in all the time and then don't clean as often as they should and then put them back on, or somebody else shares them, right? So young adults who play any kind of sport are the most common people who get these types of Staph aureus. Now, that's not the only ones. Anybody can get this, but it's just the combination of their less than ideal hygiene practices and the fact that they're constantly in these shared spaces. And in theory, depending on the sport, constantly in contact with other people's skin flora, right? If you're in football or whatever, that's a lot of close contact with people. And treatment for soft tissue infections usually ranges depending on the type of infection. This type of infection up here, right, an ingrown hair or chafing, doesn't usually require any treatment at all. A lot of times it'll go away on its own. Sometimes it requires some type of antibiotic cream or pills or IVs, which is intravenous, which means it's given through your blood. It's going to depend on the severity of the infection. Most staph infections, like this guy here, would be treated probably with a cream. Like if you went to your doctor and they diagnosed you with a staph infection, they would give you a cream for it, send you home, and you'd be fine in 5 or so days. Okay, but a really big infection like this one would probably require hospitalization, IV antibiotics, and probably surgery to clean it out. And this specifically methicillin-resistant Staphylococcus aureus is a serious threat in the CDC report. Methicillin-resistant Staphylococcus aureus, the number of drugs that are capable of killing this type of infection is getting smaller and smaller. Particularly, there's two that are used most often. One of those is vancomycin, and there's now a strain of Staphylococcus aureus that's now resistant to vancomycin. So now there's only one drug that causes significant kidney failure, and so it's going to be a problem. I know we've talked about this before, but this is just another example of it, that the infections are getting smarter than we are. So the infections are changing and adapting faster than we are developing new antibiotics. There hasn't been a new antibiotic developed to fight MRSA infections in like 20 years. And that hasn't changed. And so the bacteria, as it mutates and gets worse and worse, becomes a very serious threat. All right, so our next infection is called impetigo. And impetigo is very, very similar to soft tissue infections, but I will point out the differences. And the causative organisms here are that same Staphylococcus aureus, but it can also be caused by Streptococcus pyogenes. Notice that both of these, again, staph and strep, are both a part of the normal skin flora. Now, the biggest difference here, these are also superficial wounds. Usually on the epidermal or dermal layers, so they typically are very superficial. The biggest difference here is that they, instead of being pus-filled and wet, which I know is a gross word to apply to an infection, but instead of being pus-filled and wet, they tend to be crusty, flaky, or scab-like. So not a lot of pus involved in these, they tend to be crusty. As you can see here, these are two different versions of impetigo, and you can see they look like little crusty yellow scabs, rather than the pus-filled lesions that we saw with soft tissue infections. And they are very superficial, and most of the time they don't cause any significant side effects. Their biggest symptoms are the crusty, flaky lesions, and that they're very itchy. But other than that, they don't cause a whole lot of symptoms. They don't tend to be very serious. They don't tend to get any worse, like when we talked about the soft tissue infections. An infection that starts out like this, right, this tiny little one, can progress to something that looks like that. It can get worse, and it can become dangerous. But most of the time with impetigo, it's just itchy and flaky and gross, and then it goes away. And transmission and prevention is very similar to soft tissue infections. It's mostly spread through direct or indirect contact. This one in particular is most common in young children. It's very, very common for impetigo to spread through daycare centers and kindergarten classes, anywhere where lots of kids are. And the treatment for this, because this is not typically considered a serious infection, a lot of times it's not treated at all. And if it is treated, it's treated with topical, which means on the skin, like cream, antibiotics. So not even pills or IVs. It's mostly just cream antibiotics. Okay. Our next infection is called cellulitis. Now, cellulitis, again, if you look at the word itis, does anybody remember what itis means? It just means inflammation. So whenever you see that word, I don't know if that's how you spell inflammation. I think it is. Whenever you see any word that ends in itis, it just means inflammation of something, okay? So gastroenteritis means inflammation of your gastrointestinal tract. Any kind of itis just means inflammation of. So cellulitis just means inflammation of cells. So cellulitis is the inflammation of your cells. Your cells in your skin are infected. And cellulitis is not associated with open wounds. So as you can see, this is a case of cellulitis right here. It's typically not, it doesn't look like an open wound of any kind, pus-filled or otherwise. It's the cells themselves that are infected. So the cells get bigger, they get swollen, they get inflamed, they get red. And the causative organism most of the time for cellulitis is Streptococcus pyogenes. And the biggest signs and symptoms are pain, swelling, and tenderness, and it mostly looks like this very red, large area of skin. There's not usually, again, there's not usually an open wound. There may be a tiny, tiny little wound, but for the most part, there's not a big open wound. There's not pus production. There's not a crusty lesion. It's just that the skin becomes red and swollen. Cellulitis is known for being exceptionally painful. It's incredibly painful because of all that swelling. Okay. And transmission/prevention. Transmission is, this is a really fancy word, but it's parenteral implantation. All that means is you got stuck with something, some kind of what might also be called traumatic implantation. Now that can be anything from a needle, right? You can get this from a needle stick, any type of like getting a shot or having your blood drawn, though that's very rare because that's done sterilely. But it can happen because of piercings or tattoos, anything that is piercing your skin layers. It can also happen, so needles, again, piercings, tattoos, shots, any kind of needle piercing your skin. It can also happen because of insect bites. Any kind of anything where your skin is being penetrated. And cellulitis can happen from very, very tiny parenteral implantation. Again, one single insect bite can lead to cellulitis. One single cut with a razor, so like a cut with a dirty razor, or cutting yourself on a fence or anything, any kind of small wound can lead to cellulitis. If that Streptococcus pyogenes is implanted into the skin. And again, cellulitis, one of its hallmark symptoms is, again, the redness and swelling and the excessive pain. It's incredibly, incredibly, incredibly painful. And it usually requires significant antibiotic therapy, and a lot of times it requires surgery to remove the infected tissue. Cellulitis can be really dangerous, and cellulitis can come from, the scary thing about cellulitis is that it can happen from a tiny little wound. I saw a case pretty recently, and this is real, I think it's funny, but there was a person that got cellulitis on their neck and face because they kissed somebody that had a beard, and they got beard burn on their chin and ended up with this massive cellulitis infection, which is crazy. That doesn't happen that often, but it can come from very minor sources. It doesn't always have to be like this big, huge wound or anything like that. It can happen because of a tattoo or a piercing that you didn't take care of, anything like that. And it usually requires some kind of hospitalization. Cellulitis is a very dangerous infection. It can spread. A lot of times if it's spread to the tissue, it can spread throughout the body and cause bigger problems, which we'll talk about later. Right. So our next one is called staphylococcal scalded skin syndrome. I have to say that slowly because that's a hard one. A lot of times people just call it SSSS, which I think sounds even more cumbersome. But SSSS, staphylococcal scalded skin syndrome. And this one is written right in the name. It's caused by Staphylococcus aureus. That's why it's called staphylococcal. And it causes what looks like scalded skin. So the people who suffer from this, their skin comes off like it's been burned. It looks a lot like a burn that happened several days ago, and when the skin peels off of a burn, like when a blister pops on a burn and it peels off, that's what this looks like. It looks like their whole body was burned. That's why it's called scalded skin syndrome, because it looks like their skin had been scalded. So the signs and symptoms is a split, peeling skin, very similar to what a burn would look like. In transmission prevention, it is, again, just like all of our other skin infections or most of our skin infections, it is passed through direct contact, not usually indirect contact, usually direct contact, and it's the most common in newborn babies because newborn babies don't have a great immune system. Their immune system hasn't gotten up to its full potential yet. They're brand new. They were in a place that, in theory, didn't have any bacteria or viruses in it. And then they've come out of this world. Their immune system's not really ready yet. So that's why newborns are the most common ones affected with this. And when I mean direct contact, I mean that can either mean through the process of being born, coming in contact with the vaginal canal in some way, not in some way, that's what they do, but coming in contact with Staphylococcus aureus as they're passing through the vaginal canal, or it can happen through the process of breastfeeding, or even just somebody holding them, right? Newborn babies are often held very close to somebody else's body. And if that person happens to have Staphylococcus aureus on their skin, it can also cause staphylococcal scalded skin syndrome. It's a very, very rare infection, doesn't happen very often, but it can be very serious. It's usually treated with immediate IV antibiotics, and most babies who are treated quickly with IV antibiotics have no long-term consequences. They usually get better once they're treated with antibiotics. But it does require immediate IV antibiotics, or it can lead to bigger problems, especially death. It can cause death if it's not treated quickly. But the good news about that is almost everybody who's treated for this quickly does come away with no long-term consequences. Okay, staphylococcal scalded skin syndrome. Now, our last bacterial skin infection, not our last infection, but our last bacterial skin infection is something called cutaneous anthrax. And you've probably heard of the infection anthrax before. I know we've talked about it a little bit in here. And there are lots of different forms of anthrax. We'll talk about some of the other ones as we get to later sections. But here we're specifically talking about cutaneous. Cutaneous means on the skin. So we're talking about the type of anthrax that affects the skin, cutaneous anthrax. There are other types that infect the respiratory tract and the blood, but we'll talk about those when we get to those sections. And this one I think is pretty easy. Cutaneous anthrax is caused by the bacteria Bacillus anthracis. Anthracis causes anthrax. And Bacillus anthracis, this bacillus bacteria, is one of the bacteria that's known for producing endospores. So a lot of times it is transmitted through direct contact with those endospores. Now remember that endospores are protective structures that bacteria can produce that make them able to survive in inhospitable environments. And they can survive as an endospore for indeterminate amounts of time, decades, hundreds of years, thousands of years. So the biggest sign and symptom of cutaneous anthrax in particular is a pustule. So when we say a pustule, this just means a pus-filled bubble, which I know sounds gross. But some kind of pus-filled, not wound, I don't want to say, but like a pus-filled lesion on your skin, maybe is the right word. Like a pus-filled bubble, a pustule that becomes necrotic. And necrotic means that tissue dies. And when that tissue dies, it turns black. And when that tissue becomes necrotic, when that tissue dies, we call it an eschar. So the production of an eschar is the hallmark symptom of cutaneous anthrax. It's this pus-filled lesion that pops and becomes necrotic, meaning that the tissue dies. And when that tissue dies, it turns black, and it looks something like this. And this right here is an eschar. And transmission of this disease is typically through direct contact with endospores, so Bacillus anthracis endospores. And this is often called wool sorter's disease. And the reason for that is because these endospores are most commonly found associated with farm animals. Particularly farm animals that have some type of hair or fur or wool. So sheep, goats, cattle, not really pigs, they don't have fur. But the ones that have some type of hair, fur, hairy outer covering. And it's called wool sorter's disease because this type of infection, even to this day, is the most common in people who are around farm animals. So they call it wool sorter's disease because it can be associated with people who raise sheep and harvest their wool, but it can also be associated with people who raise cattle or goats or any other type of farm animal. Because Bacillus anthracis is just associated as normal flora with these farm animals. And if you get those endospores in an open wound on your body, those endospores can get into the wound, cause the pustule to form, and then the eschar to form. So because this is spread mostly through farm animals, this is considered a zoonotic infection. Because it's typically spread, its primary reservoir is a non-human mammal. Its primary reservoir is a farm animal, cattle, sheep, goats. Okay. Now, the big thing about cutaneous anthrax is that if it is left untreated, it has an up to 20% mortality rate, meaning that this bacteria can spread to the blood and cause what's called sepsis, which we'll get to later. But it spreads to the blood and causes a whole body infection that leads to lots of other things like organ failure and eventually death. So if left untreated, cutaneous anthrax does have a 20% mortality rate, which is very high. 1 in 5 people who get it and don't treat it will die of the infection. But again, the good news about that is that immediate treatment with IV and oral antibiotics usually clears the infection if it's caught at this stage. So if you know any farmers that have black wounds on their hands, make them go to the doctor. It's not a super common infection, but it does happen. I like to think that anybody who has a black wound on their body would go to the doctor, but you never know. Farmers are crazy. Sorry if any of you are farmers. But it does have a very high mortality rate. And again, that is cutaneous anthrax. The other forms of anthrax are a completely different story. They have much higher mortality rates if they enter different parts of your body. But when it's caught on just the skin, there's a good chance of survival if it's treated quickly. Okay. So that is all for our bacterial infections. Now we are going to move on to our viral infections of the skin. And just to warn you, I am going to get on a little bit of my vaccine soapbox one more time. And then I think that's probably the last one. Maybe not. We'll see. But I am going to get on my vaccine soapbox again, just a little bit. Kind of a lot, I guess. Okay. So our first viral skin infection is measles. And measles is caused, I like our viruses because for the most part, viruses are caused by the virus that's named after it. So measles is caused by the measles virus. That's easy. Measles is caused by the measles virus. Now, signs and symptoms of the measles are, initial signs are a very, very high fever, a sore throat, and then its kind of hallmark thing is something called these Koplik's spots. And Koplik's spots are these white spots found on the inside of the mouth. Okay, so this is on a baby. They don't have teeth yet, but this is where their teeth would be, right here. And so this is the inside of like their cheek, down by their gum line. It's on the inside of the mouth. It can sometimes be on the back of the throat, but these are Koplik's spots. These are the hallmark sign of measles. It's not really seen in any other infection type. So if you see that on the inside of a patient's mouth, they most likely have the measles. And then the other big symptom of measles is this maculopapular rash. Now I want to go back just a little bit to kind of define rashes, which sounds weird, but we have 3 different categories of rashes. Now, a macular rash is usually a rash that is flat and red. Okay, so if you have a macular rash, the rash itself is going to be flat, so flat against the skin. A papular rash is going to be slightly raised and usually also red, but it is slightly raised off of the skin. And then a pustular rash, as you might guess, is highly raised and often filled with pus. It goes along with that word pustule, like we came up with for cutaneous anthrax. And you can kind of have a combination of these. So that's macular, papular, and pustular, right? In measles, the rash is often described as maculopapular, which means that part of it is flat and part of it is slightly raised. Okay, and you can kind of see that if you look closely. There are parts of this person's body that have like a flat red area, and then there are other parts that are slightly raised. So a maculopapular rash. Now, most people, I don't want it to sound like I'm saying that this happens to everybody. Most people, I think it's like 90% of people who get the measles will have these 2 symptoms. They'll have a high fever, they'll have the Koplik spots, and they'll have an uncomfortable, itchy maculopapular rash for a couple of days. About 90% of people who are infected with measles, talking about an unvaccinated population, about 90% will have a high fever and a maculopapular rash for 4 to 5 days, and then they get better, and that's it. Most people who get the measles don't have anything else happen to them. But in about 1 in 1,000, so about 1 in 1,000 people who get the measles will develop something called encephalitis. So again, itis means inflammation. Does anybody know what that prefix encephalo means? Maybe take an anatomy? It means brain or head. So encephalitis is inflammation of your brain or parts of your brain or your brain stem. So encephalitis is an incredibly dangerous and deadly secondary infection or secondary symptom that can be caused by the measles. Again, this is a relatively rare symptom. About 1 in 1,000 people in an unvaccinated population will develop encephalitis. But encephalitis, as far as I know, is very nearly, I'm sure that there are people that have survived it, but it's very nearly 100% fatal. Okay? So if somebody develops encephalitis, there's almost nothing that can be done to help them. Again, this is very, very rare. It's not a common thing. Most people who get the measles are going to be perfectly fine, but this is something that can happen is encephalitis. And sometimes it's called measles encephalitis. There's also a much longer name if you see it anywhere. I'm not going to write it down because you don't have to know it, but it's called like soft spongiform encephalopathy. So if you see that anywhere else, that's talking about this. And transmission of measles is through droplets. So that means anything that comes out of your mouth or nose. Droplet formation is not just like spit, right? All of us, if you've ever seen those horrifying videos of somebody like talking and like they have like the crazy light set up and you can see the individual droplets coming out of their mouths. We are all producing droplets every time we open our mouths to talk. I'm not actively spitting on anybody, but I am producing droplets as I talk. And measles is highly contagious. So one of the reasons that measles is so contagious is because that virus actually floats in the air, and it can float in the air for hours. Somebody can walk into a room and sneeze and then leave, and 6 hours later, the measles will still be floating around in the air. Okay, so I think there was recently an outbreak at Disneyland, or somebody posted that there was a measles case at Disneyland, which could be a huge problem. Because they're on all those rides, they're touching all the stuff, right? They're in all the restaurants. Those people were also in LAX because they flew to Disneyland. Being on an airplane with somebody with measles, everybody in that whole airport was exposed to measles. It's highly contagious. Remember I told you that this is like the most infectious, most contagious disease. It has an R0 and R0 of 15, which means that on average, one person will get 15 other people sick. And as for prevention or treatment, or prevention, I guess, the biggest prevention is the MMR vaccine. So we'll talk about the rest of that vaccine, but MMR stands for measles, mumps, and rubella. So it's protection against 3 diseases: measles, mumps, and rubella. We'll talk about rubella in just a second, and then we'll talk about mumps in a couple of chapters. But measles, mumps, rubella, the first M in the MMR vaccine. Now, treatment for measles. Again, most people who get measles, more than 90% of the people who get measles, will not need any treatment. We give them what's called supportive care, and supportive care just means making them feel better until their body fights off the illness. So giving Tylenol to help with fevers, putting creams on their skin to stop the itching, making sure they're drinking lots of fluids so they don't get dehydrated, stuff like that. It's not going to cure the illness. It's not even really treating the illness. It's just making them feel better, treating their symptoms while their body fights off the infection. But encephalitis has a very, very high mortality. And one of the reasons it still has such a high mortality is there's actually still not really a treatment for encephalitis. If encephalitis is developed, there's basically nothing that can be done about it. There's not really a treatment for it. People who get encephalitis usually inevitably die. And again, like I said, that's not a common thing. That's not what's going to happen to most people. Most people who get measles are not going to die. Most people are going to be perfectly fine. But just to give you, again, on my soapbox a little, but before a vaccine existed for measles, measles killed approximately 6 million people a year. Okay, that's a lot of people. Worldwide, it killed 6 million people a year. Today, in countries, especially countries where vaccine access is limited, only about 350,000 people die per year. And I know a lot of people think that measles is eradicated and that it's not really a problem, and that's just not true. There are still countries that can't, I'm shaking, I'm so cold. There are still countries where measles vaccines cannot be afforded. People can't afford them, they can't get access to them, and so they don't get the measles vaccine, not because they don't want them, because they can't afford them. Okay, so about 350,000 people die each year of the measles still in 2025 or so. And I know in the US we don't think about that much because I think the number of people who died of the measles last year was 3 in the US. Maybe it jumped to 5, but it was, less than one hand. And so we like to, we focus on what's around us for good or for bad. We focus on what we feel like impacts us. But there are still 350,000 people dying of something that could be prevented with a vaccine. Okay, and this is a letter I'm just going to put up. Again, this is my last little soapbox thing. I'm not going to read it because truthfully it's really hard for me to read. So unless you guys all want to see me cry up here, I'm not going to read it. This is a letter that was written by Roald Dahl. And Roald Dahl is the author of Matilda and Charlie and the Chocolate Factory and a bunch of other childhood books. And he wrote this letter in, I believe, 1986. So if you can read through it. But one of the things, this is about how his daughter died of the measles in 1962. She got measles encephalitis and she died. And he wrote this letter in 1986 to encourage people to get the new MMR vaccine. This was his plea to get people to get the vaccine. But the biggest kind of takeaway here is this one right here, is that the measles had turned into a terrible thing called measles encephalitis, and there was nothing the doctors could do to save her. That was 24 years ago in 1962. But even now, were a child to develop the same thing, there would still be nothing the doctors could do to help her. And the big thing that I want you to take away from that is that's still true 40 years later. That in 2026, 40 years after this letter was written, that's still true. If a person develops measles encephalitis today, there's basically nothing that can be done. It has almost 100% mortality rate. But there is something you can do before that happens, and that's get an MMR vaccine. All right. So, like I said, that's probably the end of my soapbox about vaccines, most likely. But I think it is a hot topic in the world right now. It's a very controversial topic, and I don't think that's necessarily a bad thing. I'm not telling you to blindly listen to whatever I say or whatever anybody else says, but I think it's a good idea to talk about the realities of it because, like I said, I think it's very common, especially in the United States, that we don't pay attention to the things that don't happen to us, right? Measles is something that isn't really a part of our radar for the most part. You've probably never met anybody that had the measles, unless it was your great-great-grandmother, okay? You've probably never met anybody that died from the measles or who was affected by the measles. And so it's really easy to think of it as a non-issue, and it's not. It's not a non-issue. If anything else, it's important to talk about it, and it's important to bring it up, and it's important to talk about the things that can really happen. Like I said, it's true. It's absolutely true that most people who get the measles are going to be perfectly fine, but there are a lot of people that won't be. And I think it's important not to skip over that very small but very real chance of it turning into something really awful. Okay? Just food for thought. Okay, so our next one is rubella, which again is the R in the MMR vaccine, rubella. And rubella, I'm not going to write this name down here just because I think it makes it more confusing. But if you happen to see this name somewhere else, I want you to have heard it at least once. Rubella is often also called German measles, just to make things confusing. I will never refer to it as German measles. I will never write that in your test. I will always refer to it as rubella. But if you see German measles anywhere else, know that it's talking about rubella. They're the same infection. Okay? And it's called that because rubella and measles are very, very similar, sort of. So rubella is caused by the rubella virus. Again, nice, easy one. Rubella caused by the rubella virus. And its biggest signs and symptoms are this maculopapular rash. So a very similar rash to measles. You do not see Koplik spots in rubella. So you won't have the Koplik spots here, but you will have this maculopapular rash. Now, in most people, in just about everybody, like very nearing 100%, if the infection is caught what's called postnatally, meaning any time after birth. So if that includes anything from being 2 hours old to being 150 years old. Any time after birth can refer to postnatally. So if you just catch this infection out in the wild as a child or an adult or a newborn, it doesn't matter. Most of the time, if this infection is caught postnatally, the only symptom that you're going to have is a maculopapular rash. And that's it. Not even really a high fever. There won't be any Koplik spots. It doesn't typically cause encephalitis. Rubella is not really dangerous for the most part if it is caught postnatally. However, rubella is incredibly dangerous if it's caught what we call congenitally. And congenitally, or congenital transmission, is transmission from a pregnant mother to the infant. okay? And that term applies to everything, not just rubella. Congenital means that it happened in the womb, so when a person is pregnant. And the reason that this happens is because rubella is one of the few organisms capable of crossing the placenta. So if a person who is actively pregnant catches rubella, that rubella virus will cross the placenta, or usually does, cross the placenta and infect the fetus. And again, it doesn't matter if a person catches this when they're 15 and then they get pregnant 20 years later, nothing is gonna happen. It only happens if you get your first active rubella infection during pregnancy. And if it is caught congenitally, it is a very serious illness. It has very serious long-term side effects. Deafness, blindness, heart problems, developmental delays. What they used to call this, and I think your book might say it, which I don't love, but they used to call this mental retardation. That's not the word that we use for it anymore. That's super not PC, but I wanted you to know what it is. Now we call it developmental delays. That's the nice term for it. But that's what it's talking about. And very often, if this is caught early in a pregnancy, it will cause fetal death or stillbirth or spontaneous abortion, whatever you want to call it. Okay, it will cause the death of the fetus. The fetus will be expelled from the body. So congenital rubella is a very serious illness. Again, most of the time, people who catch rubella are not going to have any problems. But if you are actively pregnant, it can cause very serious health issues to your unborn fetus, which is obviously not great. And that is why if you are planning on becoming pregnant, like if it's the kind of thing, like if any of you ever go through this, if you're planning on becoming pregnant, a lot of times they recommend that you get an MMR booster before you get pregnant. Just as like if it's a thing that you're planning. You can't have an MMR vaccine when you're pregnant, I don't think. But maybe you can. But they recommend it if it's if it's a thing that you're planning with your doctor, they'll recommend that you get a booster before you get pregnant, just to prevent you from getting rubella. And again, just like measles, transmission is through droplets. It's highly contagious, not quite as much as measles, but it is highly contagious and is preventable through the MMR vaccine. Okay? And treatment for rubella, there isn't any, because most people who get rubella don't have long-term consequences. Adults, children, newborns who get rubella, most of them have no issues. It's just if rubella is caught during the developmental process that happens when a baby is gestating. Okay, rubella. All right, our next one is chickenpox. Chickenpox is kind of a tough one, not really, but it's caused by the varicella zoster virus. So this is one of our first ones that's not the same name. But chickenpox is caused by the varicella zoster virus, also known as HHV3. HHV3 is human herpes virus 3. Okay, so it's similar to what causes like genital herpes and cold sores. It's in the same virus family, human herpes virus 3, or varicella zoster. And the main symptoms of chickenpox are an itchy papular rash. So it is a slightly raised, not typically pus-filled, but it doesn't have flat parts. So most of the time, chickenpox is these small raised bumps. They're not usually pus-filled. This child has very clearly been scratching all of theirs off, and now they've become scabs, but they're papular. They sit above the skin. And specifically in chickenpox, the rash distribution on the body is typically what we call centripetal. Centripetal means on the middle of the body, so the center parts. Not that you can't get spots or the rash on your hands and feet and stuff like that, but most of the spots and pustular or papular spots are going to be focused on the center of the body, the face, the chest, the trunk, the legs. Centripetal. And then shingles, so the initial infection, we talked about this before, but the initial infection of the varicella zoster virus is what we call chicken pox. It's usually when a kid gets it and they get the whole body filled with these itchy, raised, papular rash lesions that usually go away in a few days. Again, chickenpox is a disease that can also cause encephalitis. It's not as extreme as it is in measles, so I don't have it written here. But chickenpox can also cause encephalitis and death, but that's much less common. So the first initial symptoms of the first infection are chickenpox. But human herpes virus, just like with other herpes viruses like cold sores and genital herpes, they don't usually go away. So this varicella zoster virus, this human herpes virus, can go to sleep inside of your body. It goes dormant. And it typically goes dormant in a very specific spot that we'll talk about in just a second. But anytime after the initial infection, it's usually decades later, this infection can reemerge as shingles, which is known to be an incredibly painful and uncomfortable rash that usually happens along the nerves. And it hurts especially bad because that rash is basically sitting on top of your nerve endings. And so you'll have these open nerve endings where you have those lesions. And so any touch is like touching an open nerve. It's like if you've ever been to the dentist and they like are drilling and they hit a nerve and you can feel it go straight like to your spine. That's what it feels like. So when chickenpox goes to sleep, chickenpox usually goes to sleep, that varicella zoster virus goes dormant the place that it likes to go to sleep is in those thoracic nerves. And those are the nerves on your spinal cord that run from like your upper back to like your lower back. Okay? Usually like it's called your trunk, like below your shoulder to your hip. Those are your thoracic nerves. And so that virus is gonna go to sleep somewhere in those nerves. Sometimes it's all along those nerves, sometimes it's only in one spot. But what happens with shingles is that rash will reemerge, but only along those nerves. So the major symptom of shingles is a rash that is isolated to somewhere on the trunk. So most people who have shingles will get like a strip of it across their rib cage or across their back, okay, somewhere where those nerves are. Chickenpox, the initial infection is usually all over the body, with the focus being the centripetal areas, the center of the body. Shingles usually reemerges as a single rash in one area along those thoracic nerves. And it'll be interesting to see. So I think we've talked about this before, but so my generation was the last generation that got chickenpox, like regularly. The vaccine wasn't introduced until 1995 or 6, maybe. Maybe it was earlier than that. But I was born in 1987. I had chickenpox before I was 3, so I had it before the 1990s. And I think the vaccine was introduced in the early 1990s, I think. And so people about my age, right, I'm getting to be close to 40, people about my age were the last generation to have chickenpox on the regular. And shingles usually reemerges when you're in your 60s, 70s, 80s. So it'll be really interesting to see people your age, because most of you got chickenpox vaccines. What's gonna happen? Is shingles just gonna be non-existent? Right, people my age, I'm staring down the barrel of having to get shingles vaccines now. I'm that old. I'm gonna have to start getting shingles vaccines to prevent me from reemerging with shingles. But it'll be interesting to see if the chickenpox vaccine is effective enough long-term so that you guys don't have to get shingles vaccines. But there's no studies on that yet because you guys were the first ones to get chickenpox vaccines and you guys aren't in your 40s or 50s yet. So that'll be an interesting thing to see as you guys get older. Like I said, my generation will probably be the millennials or elder millennials, will probably be the last people to get shingles regularly. Okay? So transmission, again, this is droplet contact. It's highly contagious. The most direct way to contact it is through contact with lesions. So touching, usually chickenpox would spread through schools, through a household. If one sibling got it, the rest of the house got it. Anybody who comes in direct contact. It's highly contagious. There is a vaccine available now. I think most of you probably got it. Yeah, it was available in the early 90s, I believe. And treatment for chickenpox is usually none. Sometimes they give you itchy cream, calamine lotion to prevent you from itching and scarring yourself. Again, most people my age, mine is on my shoulder, but most people my age have at least one chickenpox scar. So we all have at least one spot that we scratched and scarred over. It's a very specific looking, it's like a little divot. Looks kind of like an acne scar, but it's like one little spot. Mine is on my shoulder, but most people my age, if you ask them, they have a chickenpox scar somewhere. Because scratching was just impossible to do, not to do. Okay, so our next one, I think this is our last virus, is the smallpox virus. It is caused by, or the smallpox infection caused by the variola virus. And the variola virus, smallpox, its hallmark symptom is a pustular rash. So not a papular rash, a pustular rash filled with pus. And its distribution is centrifugal, which means the outer portions of the body. Right? Centrifugal force is like that force that, like if you're spinning in something, right? You're going in a circle on like a merry-go-round. It's the force that pushes you outward, right? So think about a merry-go-round, it makes you push out. That's why centrifugal means the outside. So it means the outer edges of the body. It means like the arms, the legs, the hands, the feet, the extremities. Again, not that the infection or the rash doesn't appear on the other parts of the body, but most people who had it, it had a centrifugal focus. The most of the infection, most of the pustules were focused on the centrifugal parts of the body. And the other signs and symptoms were a very high fever and severe pain. It caused very severe joint pain and achiness. Similar, I've heard, obviously I've never had it, but similar I've heard to like the flu, but like a million times worse. Just that like flu achiness, but everywhere and way worse. Transmission, again, is droplet or direct contact with lesions. Again, highly, highly, highly contagious. Anything that is spread through droplets is going to be spread incredibly easily because just breathing or talking to somebody in the vicinity can spread droplets. There is a vaccine for smallpox. It used to be very commonly used. It is not anymore because there have been no natural cases of smallpox since 1977. Smallpox was the first illness that was ever eradicated from the use of vaccines. So smallpox has been completely eradicated. There have been no cases of smallpox. We say no natural cases. There have been a couple from people who worked in the labs where smallpox is kept, but that's not a natural case. But yeah, so because it's been eradicated and nobody has gotten an infection since 1977, they stopped vaccinating for smallpox many, many years ago. This is a picture of a smallpox scar. I think we talked about the vaccine and how the original vaccines where they take a little bit of the virus and put it on the outside of your skin and then poke holes in your skin in a circle to introduce it to your body. And that's what that scar looks like. That's from the needles going in there. And the vaccine usually caused like a pustule to form and then burst. And that's what that scar is from. But yeah, smallpox was incredibly deadly. There were many, many epidemics and pandemics caused by smallpox. Incalculable people died of smallpox before the vaccine was created, but it was a disease that was eradicated and we don't have it anymore. If smallpox was ever released back into the environment, we'd probably all die immediately because none of us are immune to it anymore because we haven't been immune to it since 1977. But yeah, so that is our last viral infection of the skin. Next time we'll talk about the fungal infections.